Assalamu alaikum. Welcome back to my channel. Today we will discuss hypertrophic cardiomyopathy and HOCM. This is a genetical cardiac conditions where the heart muscles becomes abnormally thick, especially the intraventricular septum. In this lecture we will cover the definition, types, pathophysiology and echocardiographic findings, LVOT gradients and MR differentiations. Hypertrophic cardiomyopathy is defined by the presence of localized or generalized left ventricular hypertrophy equal or greater than 15 mm of wall thickness in the absence of hypertension or other factors like aortic stenosis, coarctations of aorta, or systemic disease like amyloidosis. Lower cutoff is 13 to 14 mm if the family history is positive or gene positive. There is some types of HCM. Sigmoid HCM is most common. Second one is a reverse curve HCM. We call also asymmetrical septal hypertrophy and apical hypertrophy, also called Yamaguchi syndrome, and Spades type, and neutral HCM. We also diffuse HCM. How to diagnose HCM on echo? In 2D image, best visualize asymmetrical septal hypertrophy. We measure the septal and posterior wall with these techniques. A septal to posterior wall ratio 1.3:1 or more will be abnormal hypertrophy and used to establish the diagnosis. This is called asymmetrical septal hypertrophy. As you see, I am measuring the septum, which is 1.8, and the posterior wall, which is almost 0.8. So we divide 1.8 into 0.8, which is of the posterior wall, so the ratio will be 2.2. so this is more by 1.3:1. So this is abnormal hypertrophy and we establish the diagnosis. This is asymmetrical septal hypertrophy. This is another case of asymmetrical septal hypertrophy with alveolar obstruction. You can clearly see the thickness of intraventricular septum compared to the posterior wall, which is the ratio is above from 1.3:1, and also the same systolic interior motion of the mitral interior leaflet, which is creating alveolar obstruction. So this is HOCM case and asymmetrical hypertrophy. This is the apical variant of HCM. The more we go to the apex, more it will hypertrophy is appearing. As you see the apical chart axis view, how much is hypertrophy, and the four chamber you can clearly see the apex in the apical segment is more hypertrophied and resemble like a Spades shape. Also call it Yamaguchi syndrome. This is a neutral type of HOCM. You can clearly see in the parasternal window the systolic interior motions of the mitral valve, which can obstruct the LVOT, and the chart axis you can also observe the mitral movement, the mitral interior leaflet movement, which is hitting the septum. And you can clearly see in the chart axis window, this is almost a concentric type of hypertrophy, not a asymmetrical septal hypertrophy. So this is we call neutral HCM or diffuse HCM. So far you have seen different types of hypertrophic cardiomyopathy on 2D echocardiography images. Now let's look at the M mode, which is the actually the best modality to demonstrate systolic interior motions are same. First look at this normal M mode image of the mitral valve. You can see that during systole the interior mitral leaflet moves posteriorly away from the intraventricular septum. There is a clear separation between the mitral valve and the septum. This represents normal mitral valve motions. Now compare this with the M-mode image in HOCM. In addition to the wall thickness, there are associated structural abnormalities of the mitral valve apparatus. As a result, during systole, the anterior mitral leaflet moves anteriorly toward the intraventricular septum. This abnormal intraventricular movement is called systolic anterior motions or SAM. As you see, this is the diastolic phase when the mitral valve open, and this is the systolic phase when the mitral valve close. But in normal condition, this is away from the septum, and HOCM, this will be hitting the septum and creating a alveoli obstruction. The systolic contact between the anterior mitral leaflet and the hypertrophied septum leads to dynamic alveoli obstruction. At the same time, abnormal leaflet coaptation result in mitral regurgitations. Now focus on the Doppler tracing. An important feature you should notice is that the peak velocity occurs in late systole, not early. As you see in the image, the lower one as HOCM, which is in late systolic peaking, not early systolic peaking. We call it a digger shape. Why is it late peaking? This late peaking tells us the obstruction is dynamic, not fixed. In HOCM, the alveoli obstruction gradually increases during systole. As systole progress, systolic anterior motion of the mitral valve becomes more pronounced, narrowing the outflow tract further. That is why the maximum gradient develops in the mid to late systole, as you see in the image. In contrast, in fixed obstructions such as aortic stenosis, as you see in the image, the upper one image, the obstruction is already present at the beginning of the systole. Therefore, the gradients rises early and peak early at the time of the maximum flow. So early peaking suggests fixed obstruction, while late peaking is the hallmark of dynamic alveoli obstruction seen in HOCM. Now, as you see, the fixed obstruction and the late peaking obstruction, fixed obstruction is the AS and the alveoli obstruction difference from the jet. Here is you can also seeing the mitral regurgitation with the alveoli obstruction. So the smaller one is the alveoli obstruction, and the bigger one is the mitral regurgitation, because mitral has already mitral regurgitation has a highly velocity. Because at the same time, same of the mitral valve also causes mitral regurgitations. However, the MR jet is different from the alveoli obstruction jet, and it is very important to differentiate the two on Doppler, because in HOCM the CW Dopplers beam often pick up both signal, as you see clearly in this image. Both of the jets at the same time and in one frame. So first remember that the mitral regurgitation jet usually has a much higher velocity compared to alveoli obstruction. As MR velocity commonly exceed 5 to 6 meter per second, where alveoli obstruction velocities are usually lower. This is as a good example of the alveoli obstruction and the mitral regurgitation, because the CW Doppler pick both at the same time. Here you can see in this clip, in this image, the late peaking and the digger shape. You can see where I have Meyer. So this velocity is less than 4 meter per second, but in that time you can also see the mitral regurgitation jet also in this place, which is exceed from the 6 meter per second velocity. So there is a little difficulty to differentiate both of them from each others, but you can see from the digger shape, and you can differentiate from the digger shapes and the high velocity of mitral regurgitation and the digger shape of the LVOT obstructions. In this video you can see this is the mitral regurgitation and also the LVOT obstruction, and because the CW Doppler picked both at the same time, so we will differentiate it from its shape and the higher velocity. The lower velocity and the digger shape and the late peaking is the LVOT obstruction, and the higher velocity, which is you see the greater than exceeds from the 5 meter per second, so this will be the mitral regurgitation. So carefully align the cursor and watch its shape of the jet. If it is a digger shape and a late peaking, so this will be a LVOT obstruction, and if it is a higher velocity, so this is will be the mitral regurgitations, and a dense envelope as will be mitral regurgitations. Now carefully look at this image, there is both of the jets are present, the LVOT obstruction and the mitral regurgitation, both of them are present at the same time. The carrot shape and the late peaking is the LVOT obstruction jet, and the parabolic and the more the full envelope is the mitral regurgitation jet. You can also see here the carrot shape and the full envelope and almost evolution type, and here you can see the carrot shape echogenic and the MR parabolic site. Look at this video clip, and this is the HOCM patients. You can see the LVOT obstruction and the posterior directed jet of the MR, which is severe MR. So whenever we put the cursor at the LVOT area, so the Doppler can pick the LVOT obstruction and also the mitral regurgitation jets. So very carefully you will align the cursor and then differentiate it from the mitral regurgitation, and get the P gradient from it. How to report the HCM patient? We measure the septal wall and the posterior wall thickness, as we done already in a routine echo. We write in a report, and in CM patient we also write a maximum thickness with the septal wall and the posterior wall. We also write the maximum thickness which is anywhere in the LV. So we will write three parameters, three measurement of the thickness: one the septal, second the posterior wall, and third the maximum thickness of the LV, left ventricular. Conditions mimicking hypertrophic cardiomyopathies. There are several conditions that may mimic the echocardiographic appearance of hypertrophic cardiomyopathy. Any situation which results in relatively greater septal than posterior wall thickness potentially could be confused for isolated pathological septal hypertrophy. As you see in this video, that patient with left ventricular hypertrophy related to hypertension and concurrent coronary disease with an inferior myocardial infarction, the subsequent reductions and the wall thickness of the posterior wall related to coronary disease in conjunction with the hypertension related hypertrophy of the remaining walls create a pattern which mimics classic hypertrophic cardiomyopathy. More conditions which is mimicking hypertrophic cardiomyopathies like cardiac amyloidosis. As you see in this patients, this is the cardiac amyloidosis patients, which is look like a hypertrophic cardiomyopathy. Also fixed subvalvular obstructions, spontaneously closed perimembranous VSDs, hypovolemia with left ventricular hypertrophy, excess catecholamine state with hypercontractility. So these conditions may mimic like a hypertrophic cardiomyopathies. I hope you will understand the this lecture, and you will understand better the HCM and HOCM. So kindly likes, comments, and share this video. Thank you for watching.